A common device for humidification or warming oxygen when the patient has a cannula or a mask is a bubble-through humidifier. Another means of administering humidified O2 is via a nebulizer. It delivers particulate water mist with nearly 100% humidity. The humidity can be increased by heating the water, which increases the ability of the gas to hold moisture. Because oxygen is combustible, a no smoking sign should be promptly displayed on the patient's door. CO2 narcosis is from too much oxygen in patients with COPD. Normally, CO2 accumulation at the chemoreceptors is a major stimulant of the respiratory center and our drive to breathe. Over time, some COPD patients with elevations in CO2 develop a tolerance to these high levels. So in return, these individuals, a major drive for them to breathe is hypoxemia. Pulmonary O2 toxicity may result from prolonged exposure to high levels of oxygen concentrations. In return, absorption atelectasis can occur. When high concentrations of O2 are given, nitrogen is washed out of the alveoli and replaced with this oxygen. If the airway becomes obstructed, secondary to say a plug, the O2 is absorbed into the bloodstream and the alveoli is going to collapse because the nitrogen is not there to maintain the tension. Infection can be a major hazard of O2 administration with humidification. Heated nebulizers that provide constant humidity support bacterial growth, with the most common organism being Pseudomonas. The improved prognosis results from preventing progression of the disease and subsequent cor pulmonale or cor pulmonale. Some patients believe that they will become addicted to O2 and are very reluctant to use it. The nurse should tell them that it is not addicting and that it needs to be used because of the positive effects on the heart, lungs, and brain. Generally, the recommendation is that the patient should be reevaluated every 30 to 90 days during the first year of therapy and annually after that, as long as the patient remains stable. Short-term home oxygen, which is 1 to 30 days, may be indicated for the patient in whom hypoxemia persists after discharge from the hospital. For example, the patient with underlying COPD who develops a serious respiratory infection may continue to have clearing of the infection after completion of the antibiotic and discharge from the hospital. The main types of breathing exercises that are encouraged in patients with COPD are pursed lip breathing and diaphragmatic breathing. However, the use of diaphragmatic breathing in patients with COPD may sometimes increase their work of breathing and dyspnea. A forced expiratory technique called huff coughing is an effective technique that the patient can be easily taught to bring up secretions to the larger airways from the smaller airways. Pursed lip breathing gives the patient more control over breathing, especially during exercise and periods of dyspnea. Patients should be taught to use just enough positive pressure with the pursed lips because excessive resistance may increase the work of breathing. Diaphragmatic breathing focuses on using the diaphragm instead of the accessory muscles of the chest to achieve maximum inhalation and slow the respiratory rate. However, the use of diaphragmatic breathing in patients with COPD may increase the work of breathing. Patients with moderate to severe COPD with marked hyperinflation may be poor candidates for diaphragmatic breathing. Chest physiotherapy is used primarily for patients with excessive bronchial secretions who have difficulty clearing them. Airway clearing devices include the Flutter, Acapella, and TheraPep therapy systems. Airway clearance techniques loosens mucus and secretions so that they can be cleared effectively by coughing. CPT consists of postural drainage, percussion, and vibration. It should be performed by an individual who has been properly trained. Contraindications for CPT include situations that involve head, neck, chest, or back instability, anatomic deformity, severe spasticity, and in which the patient cannot tolerate the position for other reasons. Complications associated with improperly performed CPT or chest physiotherapy with drainage include fractured lungs, bruising, hypoxemia, and discomfort to the patient. Percussion, vibration, and postural drainage assist in bringing secretions into larger and more central airways. The purpose of various positions in postural drainage is to drain each segment toward the larger airways. Effective coughing, such as huff coughing, is then necessary to help raise these secretions. In acute situations, postural drainage may be performed as frequently as every 4 hours. The procedure should be planned to occur and should be completed at least 1 hour before meals or 3 hours after meals. A thin towel should be placed over the area to be percussed, or the patient may choose to wear a t-shirt or hospital gown. Some positions for postural drainage, such as the Trendelenburg position, should not be performed on the patient with chest trauma, heart disease, a pulmonary embolus, head injury, or in situations where the patient's condition is too unstable. The Acapella mucus clearing device can be virtually used in any setting, as the patients are free to sit, stand, or recline when they're using it. The patients may also inhale through it, and nebulizers can be attached to the Acapella. The Acapella vibrates lungs to shake free mucus plugs. Therefore, it's going to help improve the clearance of secretions. It's faster, portable, easier, and it's very tolerable. A high-frequency pulse generator vest delivers air which vibrates the chest, dislodging mucus from the airways. It's an inflatable vest that vibrates the chest, and it works on all lobes of the lungs. It tends to be more effective than CPT. Weight loss is a predictor of poor prognosis and increased frequency of COPD exacerbations. Nutrition in COPD patients is multifactorial, including increased inflammatory mediators, increased metabolic rate due to the ventilatory effort, and lack of appetite. Other factors that contribute to malnutrition in COPD include altered taste caused by chronic mouth breathing, excessive sputum, fatigue, anxiety, depression, increased energy needs, numerous infections, and side effects of medications. A diet high in calories and protein, moderate in carbs, and moderate to high in fat is recommended and should be divided into 5 or 6 small meals a day. Underweight patients with emphysema, COPD, may need 25 to 45 kilocalories per kilogram and 1.2 to 1.9 grams of protein per kilogram to even maintain their weight. Nurses should assess the patient's dentation or dentition before broken or missing teeth or loose dentures make eating more difficult. Activities such as walking or getting out of bed during the day can stimulate the appetite and promote weight gain. Sensations of bloating and early satisfaction when eating can be attributed to swallowing air while eating. Side effects of medications such as corticosteroids and the abnormal position of the diaphragm relative to the stomach in association with the hyperinflation of the lungs. Foods that require a great deal of chewing should be avoided or served in another manner, such as pureed or grated. Assess the patient's dentition because broken or missing teeth make eating more difficult. The presence of comorbidities can make it difficult for patients to cope with the stress of an exacerbation. Thus, assessment of comorbidities can assist in ensuring comprehensive and safe management, especially during exacerbations. Older patients may have difficulty in handling the increased secretions during acute COPD exacerbation. The use of additional medications to manage the acute exacerbation can complicate disease management and increase the likelihood of adverse effects. Some medications used to treat common disorders in older patients, such as hypertension, can worsen COPD symptoms. One of the biggest nursing diagnoses that's going to be seen with COPD is going to be ineffective breathing pattern, typically related to the alveolar hyperventilation. Our goal then is going to be for them to demonstrate an effective respiratory status, i.e. their rate, their rhythm, or their depth. So some interventions that we might do that coincide with this diagnosis are monitor their respiratory and oxygen status as needed. We're typically going to auscultate their breath sounds with their health assessment every 4 hours and as needed. And we're going to encourage them to turn, cough, and deep breathe every 1 to 2 hours while awake in the beginning. And we're going to administer their bronchodilators as prescribed, their inhaled corticosteroids. We're going to position them to minimize respiratory efforts, which is going to be in a high phallic position. We're going to monitor for the respiratory muscle fatigue, which we know is just slowing down, decreased level of consciousness. And we're going to look to initiate a program of gradual respiratory muscle strengthening, usually with respiratory therapy. Another nursing diagnosis is going to be ineffective airway clearance, especially if these patients have a chronic bronchitis component, which is going to be related to the excessive mucus production or bronchospasm. So if they have an ineffective airway, our goal is for them to maintain a clear airway or an effective airway clearance. Interventions, again, we're going to assess them. We're going to observe the way that they breathe and make sure that they're not in any distress. We're going to auscultate their breath sounds for any adventitious sounds, such as bronchi, rales, bronchial breath sounds, which indicate consolidation. Those are all indications of an ineffective airway clearance. We're going to coach the patient in breathing and relaxation techniques. And in order to thin the mucus and the secretions and sputum so that they can export for it, we're going to encourage warm fluids to drink, increase hydration. Another diagnosis might be impaired gas exchange, again related to the impairment and the destruction of the alveoli. Goals are going to be gas exchange returns to baseline, or they have a maintained gas exchange. So interventions is really going to focus on what we can do to improve their oxygenation and improve the outflow of carbon dioxide. So we're going to administer oxygen as ordered to maintain their oxygen saturation levels. And we know these patients, we're going to keep their oxygen saturations lower. We're going to administer oxygen through a heated, humidified system if we have to go up just a little bit. We're always going to be checking the oxygen delivery device to make sure it's working well, to troubleshoot. We're going to monitor the oxygen's effectiveness, i.e. by assessing their respiratory status, how their oxygen sat looks. And we're going to instruct these patients on the use of pursed lip breathing, especially if they're at increased risk for CO2 retaining and gas trapping. We want to encourage pursed lip breathing to promote exhalation to get all of that gas out. And if the patient goes home on oxygen or is home on oxygen, we want to make sure that they're managing it well and that they're knowledgeable. So as far as our goals, so obviously we want to prevent the progression of the disease, because we know that we can't reverse all of the structural abnormalities with COPD, but we can eliminate some of the exacerbations and the progression. We want them to be able to perform their ADLs, have the relief from symptoms, improve their quality of life, and we want them to be knowledgeable and able to maintain themselves and implement a long-term regimen. As healthcare professionals, nurses who smoke should reevaluate their own smoking behavior and its relationship to their health. Nurses and other healthcare providers who smoke should be aware that the odor of smoke is obvious on their clothes and it can be offensive or tempting to patients. People who have COPD should avoid others who are sick, practice good hand washing techniques, take their medications as prescribed, exercise regularly, and maintain a healthy weight. Influenza and pneumococcal pneumonia vaccines are recommended for patients who have COPD. Genetic counseling is appropriate for the patient with alpha antitrypsin deficiency who is planning to have children, because we know alpha antitrypsin deficiency increases the patient's risk for acquiring COPD, especially in the setting of smoking at an earlier age. In the acute care, this is typically going to be required for patients who have acute exacerbations, severe pneumonias, right-sided heart failure, or acute respiratory failure. So the degree and severity of the underlying respiratory is going to be assessed. And then when these patients go home, our focus is going to be on pulmonary rehab, activity considerations, their sexual activity, sleep, and psychosocial considerations. Pulmonary rehabilitation can be done in an outpatient or inpatient setting, or even in the home. Works best if the patient starts it when the COPD is in the early to moderate stages. A mandatory component of any pulmonary rehab is exercise that focuses on the muscles used in ambulation. In PR, an interprofessional team works together to individualize the treatment plan for COPD patients. Physical therapists or nurses who have experience in pulmonary care are often responsible for the management of pulmonary rehabilitation centers. A large part of your role is to teach patients self-management of their disease. Frequently, the patient has already adapted alternative energy-saving practices for ADLs. Alternative methods of hair care, shaving, showering, and reaching may need to be explored. An occupational therapist may help with ideas in these areas. Alternative methods of hair care, shaving, and reaching may need to be explored. If the patient uses HOMO2, oxygen should be used during activities of hygiene because they are energy consuming. Walking or other endurance exercises such as cycling combined with strength training are likely the best intervention to strengthen muscles and improve the patient's endurance. Some patients benefit from using their B2 adrenergic agonists or their bronchodilators approximately 10 minutes before exercise. The nurse should instruct the patient to wait 5 minutes after completion of the exercise before using the bronchodilator to allow a chance to recover. During this time, slow pursed lip breathing should be used. People with COPD frequently have to deal with many lifestyle changes that involve decreased ability to care for themselves, decreased energy for social activities, and loss of a job. It is important to convey a sense of understanding and caring to the patient. The patient with COPD may benefit from stress management techniques such as massage, muscle relaxation. Teach patients about the treatment and disease, which can give them a sense of control of their disease in complex treatment regimens, and include the patient's caregiver in the teaching. Support groups at local American Lung Association chapters, such as Better Breathers Clubs at hospitals and clinics, can also be helpful. The nurse will need to first assess the patient related to sexuality and concerns of functioning. Ask open-ended questions to determine if the patient wants to discuss any of these concerns, such as, how has your breathing affected how you feel about yourself? Or how does your shortness of breath affect your desire for intimacy? Erectile dysfunction can occur with COPD as with many other chronic diseases. Using an inhaled bronchodilator before any activity can help ventilation. The hyperventilation of the lungs and the reduction in ventilation can result in severe drops in O2 saturation during sleep. This leads to a strain on the heart most likely the right side of the heart. In addition, hypercapnia may develop with more frequent wakenings. The net result is poor quality of sleep and awakening feeling unrefreshed and still fatigued. If the patient is prescribed oxygen, it should be used as it will help decrease the insomnia and the hypoxic events. End-of-life considerations with COPD. Symptoms can be managed, but remember, like we said, COPD cannot be cured. So as the disease progresses, end-of-life issues and advance directives are important topics for discussion. They're important conversations to have, but they're also difficult. Although we have our own opinions about end-of-life care, it's important to understand and respect our patients' wishes. And being that from state to state the laws change, it's important that we know what the law says in the state we work. Palliative care, end-of-life, and hospice care are all important components in advanced COPD. In addition to just being a place for them to die, it is a place that they can have their dyspnea and their pain well controlled. It's going to improve their quality of life, and it's also going to let them pass with dignity. Some of our expected outcomes, if we're going to evaluate all that we've done for COPD patients, we want them to return to their baseline respiratory function. We want them to demonstrate an effective respiratory status, clear audible breath sounds, a clear airway because they can effectively cough, maintenance of their normal body weight, feeling of being rested and improvement in their sleep, awareness and early seeking of medical attention, behaviors that are going to minimize the risk of infection and that they're going to be without infections.